The week ending June 14th is very similar to other weeks, and the theme is about finding out about outbreaks too late. Too late to take really targeted actions to extinguish things early. And I think the Ebola outbreak is a great example of that because by the time it was noticed, it had a lot of momentum, a massive head start. There was an article in Reuters that published in the last week trying to go back and figure out who the index patient was, the first patient in this outbreak. If you look at the official records, it'll say it's a healthcare worker. But we know that's not true because healthcare workers acquire their infections from patients they take care of. There was an article, the article talks about a religious figure who dies of a disease called peritonitis, which is inflammation of the lining of the abdomen. It could be from Ebola, but this person wasn't tested. But what's interesting is on the way to his funeral, there's some kind of damage to his coffin. It cracks. They have to move the body, handle the body. And his funeral seems to have served as a nexus point for many subsequent Ebola cases. So was this the first patient? Was this a super spreading event? Really interesting things to know. And the genomics are showing that this probably was spreading for months before anybody knew about it. And I think that's one of the key lessons, that you cannot let viruses spread unchecked and not expect to have a major out of control outbreak to deal with. When you think about where this is in the DRC, in the Ituri province, North Kivu, South Kivu, these are war-torn, famished, militia-run, anarchic areas. And that makes it very, very difficult to get resources there to actually understand what's going on and to get trust from the population. We've seen fatal cases coming from displacement camps, and this is going to be an area where there are displacement camps because of all of the other things going on. There have been cases in orphanages, and all of that really speaks to the fact that this is a complex disaster or a complex system of interacting emergencies. And when you read this interview that Dr. Tedros, the WHO Director General, did with STAT, he talks about the fact that people there think of Ebola along a whole other list of threats to their lives, from militias, from famine, from whatever it might be. And Ebola is on a long list, and it might not even be the most dangerous to them. So they may not care so much about Ebola, especially when people aren't dealing with kind of the structural issues that have plagued this area, which is kind of almost like these are failed states or failed provinces in the DRC. So that's why this is so complex, because you've got an interacting synergism amongst all of these that an infectious disease, as they always do, is feeding on. So this is going to take time to actually get a handle on. And when you think about the infrastructure there, it's still to the point where we're running out of tests. I read this week that 3 labs in the DRC ran out of testing supplies. If you cannot test people for Ebola, you won't know what they have because there's overlapping symptoms with many things like malaria, typhoid, whatever it might be. Basic outbreak management, you need to know who is sick, who is infected, who is contagious, who is not. You cannot stop chains of transmission if you're running out of tests. What would have made this better? How would they have known earlier? One thing that you keep hearing about is USAID not being on the ground. It's important to situate that kind of proposition to understanding what USAID was or wasn't doing. So it's not the point that USAID would be the main responder to the Ebola outbreak. They might have been doing other work, but the more expertise that's on the ground, the more chatter that they're going to hear if there's an undiagnosed illness killing people. And that may have sounded the alarm earlier and allowed more sophisticated testing that would discover this rare species of Ebola causing this outbreak at an earlier stage. So that's the key thing. And when the CDC, the acting CDC director, says that USAID's funding cuts didn't hamper the outbreak response, I think he's not actually addressing that part of the question, is would resources, assets on the ground have alerted people earlier and made this easier to extinguish? And it's not just me analyzing that or saying that. There were 2 pieces relating to USAID that published in the past week. One was an interview in STAT from a USAID worker who describes kind of the Herculean efforts needed during the 2014 West African outbreak. That was the first Ebola outbreak that USAID responded to. And if you remember, there was a czar appointed by President Obama. His name was Ron Klain. He went on later to become the chief of staff of President Biden. But that czar, who wasn't a doctor, had a lot of influence in how that response was shaped because He was an expert at coordinating different sections of the federal government, coordinating with the international groups. And that might be what's needed eventually to extinguish this outbreak. The other USAID piece was a New York Times op-ed by Jeremy Conondike talking about basically the same issue, that this is going to take a major effort to extinguish because of all of these antecedent factors that I mentioned. I wanted to talk about a couple other pathogens just to say this is not just about Ebola. So, avian influenza. In the past week, there were new outbreaks that were in poultry in Indiana, Illinois, New Jersey. But in the reports, there was nothing about any humans. Did any humans get tested? Did any humans test negative? We don't know. This is kind of not the same thing as Ebola in the sense that here we have the ability to test humans. We know that this is happening, but it's see no evil, hear no evil until there is evil. And I think that's going to be something very difficult to deal with. Salmonella. This sounds very garden variety, but there's an outbreak of 62 cases involving multiple states with no identified source and no recall. That's not how you respond to salmonella outbreaks. That's not how you respond to any outbreak. You need to understand that whole transmission belt. And I'm sure they'll figure this one out with salmonella, but it's an example that it doesn't always have to be an exotic thing where we have unknown cases occurring. Hantavirus, another example where 23 days that ship was at sail with a hantavirus death, not knowing that they're dealing with hantavirus, and a flat-footed response from the CDC, and then kind of this weird disproportionate response with the quarantine in Nebraska, really strict home monitoring that doesn't make sense. And I just read an article in Reuters, or I think in the Associated Press, about a woman, an American, who got off that ship early, like a bunch of people did, and then flew and ended up on a remote island called Pitcairn. At a cost of several $100,000, the U.S. State Department is trying to get her to Easter Island and then eventually somewhere to Argentina, I think, and then back to the United States. I don't know what's going on there because it seems a little bit disproportionate. We're very far into the incubation period. Yes, it's a 42-day incubation period, but she's not sick. We've had really no cases for a while. We're getting closer to being in the clear. I don't know why this person needs to be repatriated at $750,000 cost. It just seems strange. Just like when they were going to put police guards in front of people home monitoring, that also seems strange. So I don't really understand the mechanics of the hantavirus outbreak, but I think it kind of fits with some disarray in how infectious disease responses are going. So there is a counter model to this, what seeing clearly can do. And I wanted to kind of talk about the World Cup, which is ongoing right now. There's been several stories about this, the Georgetown University, what I would call a fusion center, where they're taking genomic data from wastewater, social media data, and trying to understand what's circulating in World Cup cities. And they're doing it in multiple different cities. I think it's a really interesting project. They've seen rotavirus, hepatitis A, norovirus. Those are all crowd diseases, what you would expect. Remember, this is a mass gathering event. And I think that's really what is likely to be the case. So, but also things like measles, flu, COVID, STIs, including Mpox. When the World Cup is over, it will be really interesting to see how successful was this fusion center? How valuable was it? Because this might be a norm that you want to do, is have fusion centers like that operating all the time, not just in mass gatherings, and give people a lot of situational awareness about what's going on in the city so that anything's abnormal, you pick up much, much earlier. And in that vein, what these fusion centers can cause or do is they create epidemics that didn't happen. And that's actually a report that former CDC directors group Resolve releases every year to talk about wins that you didn't see because they were invisible, because they stopped something bad from happening. And I think that's kind of the paradox, is that when all of these systems are working good, they're seamless. You don't see them. They're in the background, keeping you and keeping civilization safe. And because they're in the background, they get underappreciated. And that's kind of the point I make, that infectious disease doctors, epidemiologists, public health, we're sort of civilization defenders. In the background is kind of usually what we want to be doing all this stuff. You don't want to be responding to a very visible outbreak where lots of people are dead and hospitals are crushed. You'd rather extinguish it before it ever happened. Another really good example is the medical countermeasure response to this Ebola outbreak. Again, this is a rare species of Ebola that doesn't have countermeasures. The New York Times had a really good article talking about the fact that treatments are quickly moving forward. Monoclonal antibodies, antivirals, and they actually detail the treatments that Dr. Stafford The American surgeon who got infected and was treated in Berlin, what he got? He got remdesivir, which people know from COVID, as well as a monoclonal antibody. And there are more trials like that going on. And this is because people were poised to act very quickly. So that has to do with a proactive stance towards an outbreak. And now I wanted to talk just about something a little bit different. The HPV vaccine, which I say is a vaccine that gives you freedom from certain cancers. And Liz Szabo, a really great science journalist at CIDRAP, had a 3-part series. And I just want to kind of recap some of it. Part 1 framed the vaccine, I think, correctly as showing how it gives people freedom from cervical cancer deaths. That's a good way to frame vaccines. They are giving you freedom from a certain infectious disease. They are a positive on your life because they help you to achieve your life free from an infectious disease, or in this case, free from cervical cancer. It is an individual benefit. The vaccine doesn't restrict you, it frees you. Part 2 had a really important message about the fact that HPV vaccine and HPV is not just something to do with cervical cancer, but also head and neck cancer, which males get. And in that article, there is a quote talking about the HPV vaccine being even more transformational for head and neck cancer than it was or is for cervical cancer. And I think that's also the important answer to why vaccinate boys. They're not just vectors for HPV, transmitting it from male to female sexually, but they also are at risk for head and neck cancer. And I think that's an important point to make. Freeing boy, or freeing anyone, from head and neck cancer as well as cervical cancer and a whole slew of other cancers. And part 3 talked about the fact that some countries are going to eliminate cervical cancer because of the high uptake of the vaccine. Places like Australia and other places. In the US, Massachusetts is the closest to that, but the country as a whole is not. Mississippi is the worst state. HPV vaccine is one of the most valuable vaccines. And paradoxically, or maybe not paradoxically, because I think this is all nihilistic, it's the most attacked and maligned vaccine. So to close, situational awareness is the whole enterprise when we're talking about infectious disease management. You can't respond to what you can't see. The Ebola outbreak, months-long head start. The avian flu, kind of blankouts. What's going on the human side? We don't know. Salmonella without a source. This is the same failure under kind of different guises. It's lack of diagnostic testing. It's lack of situational awareness. And it allows things to build up. And then you notice them when they bubble over. And now you don't have the good tools anymore because it's too big. And I think that examples like what's going on at Georgetown, the epidemics that didn't happen, that type of work, that's what we're trying to do, build systems that can see early. And I think it's not a technological issue anymore. It's now just the will to do it because we have all of these pieces put together. The question is going to be whether we choose to